Hello and welcome to Nick Barlow Radiology. This short video is done for a collaboration with Leeds University for their professional practice module, and it's just to run through the basics of image commenting. So what I'm going to do, I'm going to split it into one MSK study, which is this elbow, and a chest study, just because they're slightly different. But the essential principles are the same. Okay, so the first thing that we're going to do is check the patient's identification with that on the indications, because unfortunately sometimes the wrong indications get put in the patient's packet for a number of reasons. Okay, so we check the patient's name and the date of birth, and that's usually in this top left or bottom left section here on packs. Obviously, we've not got it on these to keep the patients anonymized, but that's where you should be looking and checking with the indications. Make sure you've got the right indications as well. Sometimes they'll say injury to the right elbow, for instance, and when you look, it's the left elbow. So it might be a case that the clinician's just written the wrong side by mistake, but just going to need to check with them. Okay, so check that the indications match the x-ray. Once you've done that, have a look for anatomical marker. Okay, now unfortunately these days it's quite rare that a marker gets added at the time of exposure. This should be done for medical legal reasons. Say it doesn't happen very often, but as radiographers, once qualified, really you guys should be adding anatomical markers where possible. If you can, then obviously do it post-processing. But from a medical legal point of view, it should be added at the time of exposure. So make sure that these markers are correct. Make sure that the right ones have been used. Again, I see quite a lot where a right marker would be added to this by mistake. Have you got the right amount of images? So with an MSK study, it's almost certainly going to be 2 images or more, because these are 2D images and some fractures you can't see on one image. Okay, so this one, we've got an AP and a lateral. Sometimes you'll have multiple views depending on what it is you're looking at, but as a minimum, as a rule of thumb for MSK, it should be AP and lateral, as you know. So just make sure we've got the right images there and there's none that's been failed to send. Once you've done that, have a look for collimation. So we should get lateral skin borders either side. For elbows, we should get distal third of the humerus, proximal third of the radius ulna, which we've got on both of these. Have a look at where it's been centered. That's going to affect if we can see into the joint. This one's really nicely positioned, this lateral. But we need to be mindful of any rotation, because that's going to affect our visualization of the joint spaces, potential loose bodies, etc. On elbows, we check alignment in 2 ways. So we can do a check of the anterior humeral line. So if you run a line down the anterior aspect of the distal humerus, this should pass through the proximal third or middle third of the capitellum. So that's fine. And then we have the radiocapitellar line. If you draw a line through the center of the radial head, passing through the center of the capitellum. So that's how we check alignment. So that alignment is nice on there. And same for AP, we can just check that these bones line up nicely, which they do. Then we need to consider image exposure. So it's very rare these days that images get massively over or underexposed, and the digital processing can manipulate that, so it's not as obvious. But when we're checking things like bone mineral density, it's really important to consider exposure, because just if the image is massively overexposed, then the bones could look a lot darker than they actually are. It could give the impression of osteopenia when in fact they're normal. So we just need to check that image exposure. This one's absolutely fine. We can see trabecular markings nicely there. Really good bone detail on both x-rays. We can have a look at the cortex. That's good thickness as well. So it doesn't look like this patient's got any underlying osteopenia. Things like rickets, developmental disorders can give osteopenia, and that's significant because these patients are more at risk of fracture through injury. So if we do further assessment of the bones then, so in pediatric elbows, we have what's called Critol to help us, and you'll have heard of Critol before. So that basically just runs through the ossification order at the elbow. And the first section to ossify is the capitellum here. After around 2 years. Then that's followed by the radial head, around 4 years. 5 years, we have the medial epicondyle or internal epicondyle. Then there's a little bit of a gap to 9 years, but then we have the trochlea, which is here, and the olecranon here start to ossify. And then finally, at 11 years, we have the lateral epicondyle. So in this patient, immediately, this doesn't look quite right, does it? If we zoom in here, we can see that we know that this patient's got to be 11 years or older because we're starting to see ossification here of the lateral epicondyle. But crucially, there's a gap where the bone should be at the medial epicondyle. And if we look down here, we've got trochlea, which is normally aligned here, but we've also got this bone density down here, which is in fact the medial epicondyle that's been avulsed distally. So this patient's had a fall to an outstretched hand. We have some volar stress, and that has forced the medial epicondyle to be pulled away from where it should be, which is here, down to here. Secondary things to look for with fractures at the elbow would be joint effusion. So if we zoom in again, normally you would have anterior fat pad coming down here. This is visible normally in this kind of shape, but the posterior fat pad sits in the sulcus in here. So we don't normally see that. It's only when we have a fracture, the joint fills with fluid, it gets pushed upwards when we see it. If we look at this, the anterior fat pad here, and I'll draw a line around it, is in this kind of triangular shape. And what happens is, as the joint fills with fluid, this is its normal shape, it gets pushed upwards into this sail. It's called a sail sign, into this triangular sail-like shape. And you're going to have to trust me, because I know it'd be easy to see on proper packs, but you'll have to trust me when I say that there is a faint posterior fat pad. So when you see both anterior and posterior fat pads, you have that sail sign of the anterior fat pad. This implies a large joint effusion, which has occurred secondary to the fracture. This is the avulsed medial epicondyle here, projected behind the capitellum. This one here, this large circular bone structure, is the capitellum here. Then we need to assess the soft tissue. So if the patient's had a laceration, there may be air that's entered it. So you may get some subcutaneous emphysema. There may also be foreign bodies. So if they've fallen onto gravel, for instance, could be some stones in there, could be glass. They're usually easy to see. Metal, obviously, really easy because it's dense. Things like plastic can be more difficult. It may be that you want to zoom in. You may want to manipulate the windowing. You may want to invert the image. Densities just appear that little bit better once the image is inverted. So for foreign bodies, that can really help you. Okay, and then once we've done all that, we can produce our report along with recommendations. So significant fractures will obviously need surgical fixation. They'll all need to be followed up in orthopedics. May need cast application, splinting if it's finger injuries. So just have a look at some of the follow-up options. The important thing for you guys, obviously, you don't need to go into any major detail. It's just to identify whether there's a fracture or not, basically, and then describe any of the secondary signs, like I said, with the joint effusion, any foreign bodies. The significance of if you have a laceration next to a fracture is called an open fracture. Basically, the significance is that if that wound is opened out, there's potential for infection to get into there, and for the patient to get a bone infection, which is termed osteomyelitis. So if the patient isn't given antibiotics, then that can develop and become quite nasty. So it's worth mentioning whether there's adjacent skin laceration. If there is, you can term it an open fracture, as opposed to a closed fracture if there isn't. The way we describe fracture displacement, so we can describe it in terms of whether it's so the plane in which it's moved, so proximally, distally, medially, laterally. Volar displacement or dorsal displacement if it's finger or wrist. So just have a look at some of the terminology there, depending on where it is in the body. Personally, I like to refer to the degree of displacement as minimal, mild, and significant. Moderate, I don't tend to use because it's neither here nor there. What does that mean? I got told off once by a radiologist, so I've never recovered. So I usually just go minimally, mild and significant. really, technically, non-displaced. Sometimes you'll see non-displaced fracture, but if it was non-displaced, we wouldn't see it. The only reason we're seeing it technically is because there's a gap, and that's what causes the Lucensay gap between the bone. So there has to be a degree of displacement in order to see the fracture on the X-ray. So if there's hardly any displacement at all, you can use the term minimal. If there's a little bit, mild. If there's a lot, significant. Okay, so that's the elbow. So with the chest, it's slightly different. There's more things to consider here, but essentially the main principles, those overarching checks are the same. Okay, so we check the ID, the indications. Is there a marker? Again, zoom on that. There's not added at the time of exposure again, which is a shame. Check for whether this image has been taken PA or AP. That should be labelled. Anything outside of the norm, which would be a PA, should be labelled. Whether it's supine, whether it's AP, whether it's semi-erect. What we're aiming for is PA so that it reduces magnification of the heart, which you guys obviously already know that. But this hasn't been labelled, which suggests that this is a PA study. Collimation-wise, we're wanting to see lateral skin borders. Some people will be tempted to just collimate right down here to the edge of the lung, because on a chest, some people think, oh, we're interested in is the lung. And that's not the case. You know, we've got shoulders here, we've got soft tissue of the breast, there could be pathology in there. It's important to have lateral soft tissue borders. And I'd say that this is probably about right in terms of lateral collimation. I would say probably maybe at this top end, we're probably looking for about here. I don't think we need as much neck there. And similarly down here, if it was sort of cut off to down here, that's fine. You want a little bit of subdiaphragmatic region. Again, for some patients, there may be perforation. And also what you've got to consider is, guys, that the lung actually comes down here. Hemidiaphragm obscures that. And sometimes, if we're not careful, we can cut that off. So it's just an important consideration. But on the whole, we're not doing too bad here. We've got all the areas that we need to see. Is it rotated? Well, there are things that we can do to assess that. So if we look at this here, we can look at the distance here between the end of the clavicle and the spinous process. Now, very, very minor difference on each side. There's slightly longer distance on this left side, but essentially very minimal rotation there. We can also look at the posterior ribs. Do they appear similar length, similar appearance? Which they do. So this patient isn't really rotated either, which is nice. This is a good chest x-ray. Image exposure, we're looking to be able to see thoracic spine, vertebral bodies just behind the heart, which we are doing. If you're strained, you could see the end plates here and the intervertebral disc spaces. So there is enough image exposure, and you can window it to be able to see that a little bit more clearly there. You can just start to see some of those intervertebral disc spaces there. Really important consideration with the chest is that, as I talked about with lung in these subdiaphragmatic regions here, we've got to consider these apical regions, that there is a lot of rib, a lot of clavicle overlying it, and similarly, the cardiac silhouette obscures a large portion of the left lower lobe as well. Sits behind the heart. So it's important as a second check, always second check these three areas at the end of your review. It really helps if you window the image. It helps even more if you invert it. And the eagle-eyed amongst you will have been able to see. It wasn't obvious on initial viewing, but actually now we've inverted it and windowed it, we have this lobulated soft tissue mass area here behind the heart. So this turned out to be a left lower lobe cyst, but could easily be a cancer. And unfortunately, cancers have this nasty habit of hiding. Typically behind the first ribs, but sometimes at these extreme lung bases or behind the heart. So if you take anything away from this, when you're looking at chests, just remember to invert the image and check at the apices behind the heart under the hemidiaphragms as a second check. So what have we done? We've done ID, we've looked at markers. Have we got enough images? Well, normally you would just do a PA chest. Sometimes we do laterals for pacemaker checks, but it's rare that we would do a lateral as standard these days. So more often than not, unlike MSK, we would have a minimum of 2. We usually just have 1 to go at. That's not to say that you couldn't recommend a lateral if you're unsure about something and you wanted to double check if you thought there was potentially a mass behind the heart, or you could do but to be even if there was one, they would need a CT anyway. And a lot of the time, if there's any concern of a cancer or anything like that, they will go straight to CT. You wouldn't do extra x-rays for that. So once we've done all those checks, the exposure's fine, the collimation's fine, with no rotation, ID's okay, marker fine, we've got enough images, then we can finally start looking at the different areas for pathology. What I like to do is I like to check the lungs. So I zigzag down. I've already said, remember to check those hidden areas. Make sure you check the costophrenic angles and the cardiophrenic angles. Costophrenic angles should be nice and sharp, no blunting, because that implies either a pleural effusion or pleural thickening. Remember to check the cardiophrenic angles. You should see hemidiaphragm on this left side up to around this area. Then you start losing it. That's normal, that's fine. But on this side, on the right side, it should come all the way to here. Should see heart borders nice and clear. You might hear the term consolidation used when we describe an area of consolidation within the lung. All that means is basically you've got an area where the air spaces have been filled with something, whether it be water, infection, blood, and you have an area of dense white within the lung, and that's termed consolidation. Sometimes you can see clear airways through it, termed air bronchograms. But that's all we mean when we talk about consolidation. And if you have consolidation up against a heart border, it'll make it fuzzy or indistinct, and that's known as silhouette sign, okay? But on this one, we've got nice clear heart borders. Have a look for any pericardial fat pads. So sometimes these appear as these triangular greyish coloured structures on either side of the heart, and you can compare with previous x-rays to make sure they are fat pads and no focal collapse or anything like that. If they've not had any previous, you maybe want to follow up just to double check in some cases. In some cases, they're really obvious in the shape and the density, some not so much. Heart size. So as a rule of thumb, PA, X-ray, the heart should be half the width of the widest point of the thorax. So it's called the cardiothoracic ratio. It should be 0.5 or 50%. If it's above 50%, then it's enlarged. To be honest, if it's 51, 52, I'll just say it's upper limits of normal because it's not exact. But if it was 57%, it's definitely enlarged. It's termed cardiomegaly. Obviously, that only applies to PA chest X-ray, which is why it's important to look at the annotations. If it's an AP X-ray, we're getting over magnification of the heart, so it's very difficult to accurately assess the heart size. If it's over 60%, then it's still enlarged, in my view, regardless of whether it's an AP or not. But if it's between 50 and 60%, you can't accurately assess it. Obviously, if it's below 50% on AP or PA, then it's normal anyway. So we go around the heart, we look at the hilar regions. These are the hilar regions here where all the main vessels come out from the center. There is something called a hilar angle here, which is an angle between the vessels. And really, all that is just to show that if there was a mass or any lymph node enlargement, you would have an outbulging of soft tissue here and you would lose this angle here. You don't need to go into detail on anything like that. The main thing for you guys, I would say, with the hilar regions is just look for any difference in density between the two. Can you distinguish the vessels coming out clearly? If one hilum looks denser than the other and it looks more lobulated, if you can't see those vessels, then that implies there's either lymph node enlargement or a mass, either at the hilum or posterior to it in the upper lobe. Look at the paratracheal regions. You have lots of lymph nodes in this region called the paratracheal stripe. So again, if there's loads of thickened soft tissue, any lobulation, any jutting out of soft tissue, it could be some lymph node enlargement there. or a mass. As we come down this side, we have the aortic knuckle coming around here. And this section here, this concavity here between aortic knuckle and left atrial appendage is something called aortopulmonary window. So that's something the radiologist uses as a marker just to assess again. If there's any mass, it'll bulge outwards and you'll lose that concavity. Have a look at the vessels, okay? So are the vessels enlarged? So if these vessels in the upper parts are the same width or greater than the lower zone vessels, then it implies hypertension. Because of gravity, these lower zone vessels should be larger. If they're not, it implies there's some, it's called upper low blood divergence, but the blood pressure's raised. There's more blood getting diverted to these upper zones. Often the lungs will look quite busy, quite congested. In patients with asthma or COPD, you can get bronchial wall thickening as well, or something called bronchiectasis, where the bronchi become dilated. So you want to check for that. It'll look, again, quite busy, quite mesh-like. In patients with fibrosis, we would use the term reticular pattern. So that's a straw-like pattern where you have loads of white strands where you've got fibrous tissue in and amongst normal tissue, or areas where the air spaces have been damaged and you have cysts, cystic areas. But we can see we've got no consolidation. The lungs look nice and clear. The markings look absolutely fine. The mediastinum looks good. The heart doesn't look enlarged. We've double-checked those 3 areas to make sure there's no tumours hiding in there. Obviously, I've talked about the cyst there. Then we'll have a look at the bones, okay? And the ribs are difficult because there's a lot of overlap. So what I tend to do to make it easier is I do it in 3 stages. So I look at the posterior ribs, then I look at the anterior ribs, then I look at the posterolateral, the lateral aspect of the ribs, and the anterolateral. So by doing it in 3 stages, it just makes sure that you're not going to miss anything, because often rib fractures can be minimally displaced, can be really difficult to spot until they start healing. Other things you want to be mindful of: if it is a trauma patient, look out for pneumothoraces, that's air within the pleural cavity. Often, because air rises, you'll see a pleural edge at the apex, no lung markings beyond it, and that would imply pneumothorax. But you can also get them at the lung bases. As they get bigger, you start to see pleural edge laterally, and in severe cases, you could get something called a tension pneumothorax, where air just keeps getting into the cavity but can't get out. So usually that's with a penetrating injury, and you have a skin flap where air can get in, but it acts as a one-way valve and it can't get out, and the pressure builds and builds. It pushes on the heart, it pushes the heart mediastinum away from that side of the thorax, and if you're not careful, eventually it can lead to cardiac arrest because of the pressure. So those patients will need a chest drain inserted ASAP. Have a look at the soft tissues, okay? So they might have subcutaneous emphysema if they've had a penetrating injury, if they've had any recent surgery, if they've got a pneumothorax. There may be a mass, there may be some calcifications, and have a look, if it's a female, have a look at the breast tissue as well. So if the patient's had a mastectomy, you can see here you've got this faint opacity over the lower zones, and that's because we've got breast tissue overlying it. If the patient's had a mastectomy, one side will look darker than the other. And if you're not careful, if you don't spot it, then you could interpret that as some pathology, like infection, for instance. So always check if it's a female, have they had any breast surgery, mastectomy, resection. Sometimes we'll have surgical clips at the axilla, which is a bit of a clue. Check for any evidence of previous cardiac surgery, if they've got any sternotomy wires, any prosthetic heart valves, any internal or external artifacts. Unfortunately, some patients may have some external clothing artifacts like necklaces, bras, etc. that's been really difficult to remove, haven't been able to remove them, and they've been left there, and that can obscure any underlying lung pathology. So it's important to comment on those as well, if there's any zips or anything like that. And it's important to check the shoulders. So we mentioned the bones, the ribs, but it's not just about the ribs. If it's a trauma patient, could be clavicle fracture, shoulder dislocations. Have a look for any destructive bone lesions at the humeral heads. Really important not to disregard the shoulders. And again, that's why it's important not to collimate too much, because if you collimate too much down here, we're missing all this area here. Could be something there, okay? But that's it, guys. Again, you know, I think the only other thing on chess, I've mentioned external artifacts, internal, so things, you know, surgical devices we talked about. Just check for foreign bodies as well, although they're not as common within the chest. Occasionally, you might get patients with lead shot in there or something random. Okay, so if there's something there, just mention it and just put it back on the clinician. You know, you could say there's an unknown metallic density, query internal, and they can correlate with that patient's history and find out what's gone on. Sometimes we don't have all the answers, and the indications are often quite vague. Okay, so there's nothing wrong with putting it back on the referrer, and then they've got the patient, they can talk to them. We don't always have that luxury, unfortunately. Okie dokie, guys. Thank you very much for listening. I hope that's been useful. For those at Leeds Uni, I'm doing so enormous luck with your module, but for anyone else listening, I hope it's been useful. And yeah, check out any further content. I'm going to keep adding content on image reporting and on radiographer careers through the year. So yeah, give us a like, subscribe and follow, and hopefully you'll find it useful. All right, guys, thanks. See you soon. Bye for now.